First of all, welcome to the SLT and MIGS Mythbusters session here at ASCRS. So if we got some great panelists here, we have Dr. Latina, we have Dr. Radcliffe who's going to be with us, and also Gallardo should be here in a very few minutes. But we're going to talk about SLT and MIGS, and I think what's kind of fun talking about these new devices and technologies is that there's a lot of proliferation in technology in glaucoma. And I think it's changing our paradigms of what we think is really important to us. And I think quality of life, decreasing medication burden, helping decrease the compliance issue is really becoming vogue in glaucoma. And so, kind of the question is, where do these devices and techniques and technologies fall in our practice? SLT and MIGS, and kind of how severe the decisions we make. Early glaucoma, mild glaucoma, moderate glaucoma. So we're going to try to debunk some of the myths that we have with SLT and MIGS. And so I'm going to have these guys help me out with some of these questions. So before we go on further, quick question for you guys. I know I hear all the time that, does SLT really work or not? And I know it's kind of funny, but there are some people who don't think SLT works. So what are your thoughts on SLT, Mark? I know you've been a big proponent for many years, of course. Does it work or not?
We would say it works.
Yeah. But let's say as a primary therapy. So,
yeah. So I think,
does it make a difference?
Yeah, I mean, I think, let me ask Milan, what questions you have, actually.
About SLT?
About SLT.
That would be my
The first question.
Oh, you're a corneal specialist, okay.
That's my question.
Does it work or not, right?
Can I kind of give the same promise and not hype, but expectations set the same as a medication?
Okay, good, right. I mean, I think that initially people were using SLT sort of as fourth-line therapy. In other words, after multiple medications, after argon laser trabeculoplasty, and then you do some SLT. And then the probability of success of getting significant IOP lowering was in the 50% range or potentially even lower. So, the question is, well, does it work? Of course, nothing works 100% in everybody. So the best of our drugs still have a 10 to 15% failure rate or non-responder rate. So then, over time, we found that, and I think the best study was still the SLT med study, comparing SLT as primary therapy to prostaglandin, in that case, latanoprost as primary therapy, and it showed that SLT showed equivalent IOP reductions in the range of 25 to 30%. Again, not everybody responds. There's a 10% non-responder rate for medications versus and/or laser. So I think that, again, if you use it earlier on in the treatment regimen, your responder rate is higher, your success rate is higher, and yes, it does work. And the reductions in pressure are also dependent on the pre-op IOP. And that's probably the biggest quote-unquote predictor of success. So again, if your usual patients in the 20 to 25, 30 millimeter range, you're going to expect to see about a 25 to 30% IOP reduction. If you're below 20 millimeters of mercury, you'll still get a quote-unquote 20% IOP reduction, but 20% of 20 millimeters or 15 millimeters can be smaller. Also there's the group of patients that are NTG patients, which we consider, well, is SLT going to be, or is laser going to be effective? You're trying to get their pressures quote-unquote lower. Well, there's two aspects, I think, to that group of patients. One is what's their mean IOP, but more importantly, they tend to have bigger diurnal pressure fluctuations. And there's been a number of studies, Ashrani and a couple of other co-workers looking at those IOP fluctuations in that group. And even in that group of patients, and there was even one other study with the SensorMed triggerfish, the contact lens study that looked at IOPs over 24-hour time period. In even that group of NTG patients, they found although the pressure did not change substantially, the mean IOP did not change substantially during the day, that there was actually significant IOP reduction at night. So, what is important in this group of patients? We're always looking, okay, is the pressure changed? Does it change by 30%? Well, you might not always get a 30% reduction in pressure, but you get these other factors which I think SLT can improve. Improvement in diurnal pressure fluctuation over time. Again, still, slightly lower mean intraocular pressure.
Yeah, I think what's key to understand is that there's no right type of pressure reduction? And then in terms of what are the risk factors? Is it mean? Is it peak? Is it fluctuation? And I think what we have to figure out is this New York glaucoma study that showed difference versus Canadian glaucoma study. So, and AGIS shows fluctuation. So each study that's out there shows mean, peak, or fluctuations can all be a risk factor. So I think what SLT can potentially do is minimize not only that spike, but also minimize the fluctuations potentially throughout the day as well. But you made a good point. You know, earlier the treatment, the better.
Right.
So let me ask you, Nate. Is this something that you can do first line? I mean, people say, do I have to do drops first, or can I just say, hey, let's just offer SLT as a first line? What are your thoughts on that?
So I really like what Mark said, because he kind of echoed how I started using the laser. When I started at Cornell's, director of the glaucoma service, getting referred one nightmare case after the next, trying SLT and not having the best success. Right. And I wondered if it worked. And then I switched practices to a group of patients who had really a lot of trouble with compliance. And I just woke up one day and said, you know, if you missed your drops, I'm going to really recommend laser. And let's see how I do with that. All of a sudden, I'm hitting it, you know, the overwhelming majority of the time I'm getting this pressure reduction, and I'm thinking, well, wait a minute, you know, I was treating these really high pressures on 4 drops. Why is it working so well? And the answer is because you're getting earlier. They don't have as much disease in the rest of their outflow system. It can be rescued or restored with the laser therapy at that point in time. You have more realistic goals. Replacing a prostaglandin analog with a laser works better than trying to get someone 30 points of pressure reduction. So now, you know, and my patients are very trusting, but they do ask me, like, what do you think is best? Like, I want to do what you think is best. Yes. No problem saying SLT is by far the preferable first-line therapy to drops. My chairman at NYU, Joel Schumann, agreed, and we actually made it department policy, which kind of meant that he and I just both agreed that we were going to start with SLT. But I think in any rational analysis of the data we have available, knowing the side effects, you know, the statistics in my head, 93% of patients on a prostaglandin analog get obstructive meibomian gland dysfunction. They get bad MGD. You know, we've got a company over there, you know, that works to fight MGD, and we can do it with a glaucoma laser that just gets the patient off a drop that's causing a lot of ocular surface disease. So I don't think it's just acceptable first-line therapy. I think there's no rational analysis that has it as anything other than
I think it's really interesting to think about, you know, what is SLT doing, right? It's targeted at pigmented trabecular meshwork cells. The idea is to open up the channels to allow the distal channels to also stay open. So, you know, when you're focusing on just the trabecular meshwork, you're actually helping flow through the canal, and that canal to the distal channel. So it's not just here, it's the distal pathways that you're maintaining potentially, theoretically, over time. When you put drugs that potentially divert fluid away from the natural outflow, like our standard PGAs, there's some new products out there now coming that have been approved for the natural outflow, but all the other products we've had have diverted fluid away from the natural outflow. So if you can maintain it ahead of time, do a procedure that can open up the trabecular meshwork, keep the flow going in the distal channels in the canal, do you have the better chance of also protecting yourself when you have to do other MIGS devices or other things, and do you decrease the chance of pressure spikes later on as well. So that's why for me earlier treatment has been, I think, a big practice builder for that sense. Now, I think also, you look at cost and side effects and compliance. I mean, there's a number of studies out there that even with one prostaglandin analog, our patients aren't compliant, right? You had a second or third. So, you know, can you use this as an adjunct too? I mean, when do you guys offer laser? So let's say the patient's already on a PGA. Do you automatically offer SLT as a second line, or do you set adding a drop, or how do you do that in your population?
Well, I'll actually answer that question.
Go ahead.
To some extent. So actually the PGA, so actually there was I actually did a study when we first started, and the question was actually, why is the SLT not working or giving us a minimal response in some patients and giving us a great response in other patients? And when we looked at that data initially, we saw that many of the patients who were quote-unquote poor responders, and that was less than 3 millimeter reduction, were actually on a prostaglandin. So we said, oh, and the others were on aqueous reduction, you know, aqueous suppressants. So we took a look at that, you know, pretty closely, and it appears that, well, you know, sort of you think about the pathophysiology, the prostaglandins are basically an outflow drug. So they're acting on the uveoscleral outflow, but they actually act on the trabecular outflow system as well to a certain degree. And there's been a number of studies, Lim and co-workers, looking at the tenography and outflow pathway, and they actually have shown that the prostaglandins do act not only uveoscleral, but actually trabecular outflow as well. So now if you do a laser, which is going to be an outflow, it's, I always say SLT is an outflow medication. You use the laser instead of taking the drop, but it's like a drop, it's like a medication without having to take it. And that's what I tell the patients. It's like having a med, except you don't have to take the medication, you don't have to pay for it. So that's a good plus for it. But the prostaglandins, again, so they're an outflow drug. The SLT is basically an outflow drug. So if you're using an outflow drug already, such as a prostaglandin, and then you're going to add laser, it's basically using the same mechanism of action and trying to augment it. Now, it does augment it at least 50–60% of the time, but not your 90% a time that we were seeing with aqueous suppressants. So you have to begin to think about the mechanism of action of what you're actually treating and what you're actually doing. So in those patients who are on prostaglandin, I actually take them off. I want to get them off the prostaglandin. I basically say to the patient, this medication is actually going to interfere with the efficacy of the laser. So I want to get you off the prostaglandin, do the laser, and then see how you do, and then adjust the medications accordingly.
Yeah, it's interesting. So we actually looked at our patients who had SLT being on a prostaglandin, and sometimes you won't see that significant reduction in pressure, but you stop the prostaglandin after doing the SLT, and they don't rise much.
They don't rise.
That's exactly right.
Yeah.
So
right.
I think that's a very common thing where your perception of SLT as well, it didn't really make a difference for me because my pressure's still in the upper teens. Didn't do anything. But then you stop that PGA, and all of a sudden it goes up maybe a point. You say, wow, they've stabilized without the PGA, and that's where you see that efficacy you're talking about. But let's talk about the issue of, can you repeat it? Because people are fearful of, well, if I do it once and I can't do it again, and do the studies really make a difference? Do they show that you can repeat it, Nate? I mean, do you guys find that you can repeat it in your practice?
Well, I think this is all Mark's data, but let me present it.
Mark, you want to do it? I'll let you.
Let's see what Nate can do. Presenting other people's data. Why stop now? No, so it is repeatable, but interestingly, and correct me here if I'm wrong, how successful the first SLT was is not necessarily a predictor of how successful the second is. And to me, that's a fundamental lesson of glaucoma, which is never let logic interfere with your ability to treat glaucoma patients. They follow their own rules.
Exactly.
And and also the concept that if you have a patient, you tried the laser and you maybe fell short of your goal, it's entirely reasonable to try a repeat therapy, and then you may hit it. And and this has actually been shown with Ahmed valves as well. So there's something about glaucoma where persistence pays off, and so it's absolutely repeatable. And in fact, I've found that patients kind of understand that model of care. Some other observations I've had is patients who are diabetic and have had other lasers are perfectly amenable and actually kind of prefer laser for glaucoma too, because they understand the model and they aren't afraid of laser at that point, and so they're very happy to be treated that way on a repeat basis.
So Mark, how often can you and how long does it last, and what are your thoughts with your studies that you've done?
So the studies actually show that if you look at SLT over time, there is a sort of a waning effect, and this has been seen with virtually every glaucoma therapy and every procedure that we do. We know from the original ALT studies, back years ago, that it was approximately 50% or so reduction in their response rate after, say, 5 years, 4 or 5 years. SLT, I think, also tends to have that average 50% or so. It's really about 60 or so percent response rate after about 5 years. So there is a reduction over time. And the question is, of course, can you repeat it? We did find that with ALT that the repeat therapy was really not that effective. Primarily, I think, because argon laser trabeculoplasty really does scar and burn the trabecular meshwork. It closes Schlem's canal in those areas. So there's really, sort of permanent damage, structural damage to the meshwork, and repeating it with another argon laser just adds, more damage to the existing problems. So SLT was repeatable, especially even after argon laser trabeculoplasty. The data suggests that if patients have a good success for at least 6 months to a year, and ideally a year, in other words, they have a reasonable pressure reduction and they respond for at least 1 year, then the likelihood of success of repeat SLT is quite high. So in other words, you're still in your 90%. What I say that is for every repeat laser that you do, your responder rate or percent success goes down by about 10%. So if you're at 90 or 80% for the first one, you're at 70% for the second, you're at 60% for the third, you're at 50% for the fourth. So that's where you are. Again, some patients, quote unquote, there's a rise in pressure over a period of two and a half years. Now we have patients that I've been out 8, 10 years, and these patients had a great response initially, a good 20–30% responder rate. They were treated as primary therapy. Those patients can be out 8 or 10 years without having to require repeat treatment. And then when you repeat them, it's like they never had any treatment before. So they respond just as well. They go back down to their initial preoperative or postoperative IOP reduction, and they can do very well. So, again, it's where you're treating these patients in their, depending on their stage of glaucoma. And I think our goal is, again, to get ophthalmologists to treat the patients earlier, with laser instead of putting them on medicine, because that duration of effect, it's changing the biochemical structure of the trabecular meshwork. It's causing remodeling and basically a quote-unquote a healing process. It does actually, we never actually published this, but it does actually activate the progenitor cells in the Schwabe's line cells, which actually help to cause trabecular meshwork cell proliferation. So it actually does increase the cell count. And so there's a repair process that occurs with laser. If you get that, there's sort of you sort of have a certain amount of sort of residual effect, I guess, in the reserve. Let's put it this way: a reserve in the meshwork. If you're at the end of the stage, you're on 4 medicines. Your cell count is way down, because that's what happens over time. You're not going to be able to do much with. To be honest with you, laser's not going to do much, nor is anything else for that matter. If you're getting them early, where you have good repair processes in place in the trabecular meshwork, and you're treating them, that's when you can get a healing, quote unquote, a real healing response, and that duration extends the duration of the effect over time.
Yeah, there's been a number of studies showing 5-year data with 80% success as well. So I think the key is this earlier adoption of SLT. Not only you get better efficacy, but you're also helping compliance for the future. You can always add a drop later on if you need to, but I think earlier adoption is important. But you mentioned ALT.
Right.
And Nate, any one of you guys have done SLT on top of previous ALT?
Well, the original FDA trial.
But like now, do you still do that?
Oh yeah, I mean, if patients have had ALT in the past, so we have patients who've been, when was your last ALT? Well, it was 1995 or something. Yeah. Well, no problem. And actually, right, you have here, is it a myth that you can't do SLT? SLT is the perfect treatment if they've already had prior ALT. Because it doesn't.
It works really well.
It works like they've never had any laser before.
Yep.
Because it doesn't cause any thermal damage to the trabecular meshwork. It's not causing any scarring. So it's actually it's the right treatment to do following argon laser trabecular.
So what if you have a patient who had a narrow angle? He did LPI.
Yeah.
And their angle open, but they have a kind of combined mechanism where you have a nice angle now. You can see the TM, but it has some increased pigmentation, let's say. Would you try an SLT on that patient?
Definitely.
I refer to that as an angle that's been primed by the iridotrabecular apposition. And if you think about where all of that disease is, I mean, like particularly, look, no one loves to tell somebody who just had 2 iridotomies, we got to do a couple more lasers, but that's the time to do it, because you've got this angle, it's freshly opened, and you know where the disease is. It hasn't gone beyond that, hopefully, if it's a relatively new case. Treat with SLT, get them off drops, and they'll end up looking like someone who just had narrow angles rather than what they really have, which is chronic angle closure with the diseased trabecular meshwork.
Yeah, there was a study also done in, I think it was either Japan or Europe, where they have a lot of narrow angles, and they did laser iridotomy. They had at least 180 degrees of the angle was still open. They actually did a prospective study comparing SLT as primary therapy versus prostaglandin in that group, and the results were an equivalence. SLT was actually even slightly better than the prostaglandin in reducing pressure in that group of patients, with actually a portion of the angle closed.
You mentioned 180 degrees. A question I get all the time, right, is do you do 180, do you do 360, right, and what do you do first? And so what is your kind of protocol for a new patient getting SLT? Healthy angles.
You know, I had started at 180.
Yeah, we all started.
Yeah, and I've graduated to 360. If it's repeatable. Look, I'm the type of person who, I love the one and done concept of anything, you know, so I'm not trying to bring them back 90 days later or anything like that. I want to give them the best treatment I can. I see no safety concern. I also still use reasonably high powers, which is kind of the other question. I did experiment a little bit with the sort of low 0.6 millijoule power SLT, and you know, I just was doing so well with 0.8 to 1 millijoule that I said, you know, why rock this boat? And so that's where I'm at now.
Will you go down in your power if you have a heavily pigmented TM?
Yes, definitely.
Yeah. And I'm pretty proactive about, like sometimes as I'm looking at the angle, I'll just ask the technician to give him some Diamox when we're done, because you know, an ounce of prevention in that case. I mean, why wait 2 hours for them to have a spike if you can immediately identify who's going to have it and be there?
Will you do less energy or less number of shots?
So if it's so PXF and definitely pigmentary, I only do 180, 180 degrees, no more than 60 spots, and no cavitation bubbles. So I'm down to 0.4 millijoules, way low.
Yeah.
And the reason is because when I actually worked on when we were developing SLT, I said this is going to be the best treatment in the world for pigmentary glaucoma, because we're targeting the melanin granule.
Yes.
That's actually what you're targeting. You're not targeting the cell, you're targeting the melanin granule within the cell. But in pigmentary, there's like melanin everywhere. There's pigment all over the place. It's an extremely efficient absorber of the SLT laser, melanin. So what you're actually doing is you're actually fracturing this melanin granule. Well, in the cell, it's okay because the cell can metabolize it and take care of it. But you have a lot of, in pigmentary, you have a lot of external, extracellular pigment, and it's fracturing those granules, and that can actually clog the drain. In other words, clog the trabecular meshwork. So, and then you get these, refractory glaucomas, pressure spikes that need trabecular, you need a trab or something. Now we got to, but the point is that it's better, so you have to be very careful in that. So we treat 180 degrees. You don't need you don't need high energies. You don't want to see these cavitation bubbles. And I'd rather go back and I tell the patient, look, we're going to treat you 180 degrees. I'm not going to use the usual spots that I do for many other patients. We may need to bring you back and treat you again, but I'd rather treat you 2 times than have a risk of a pressure spike. PXF, likewise, I tend not to go more than, say, 70, 75 spots in PXF, just also because of this, pseudoexfoliation material and the pigment that's around, and it's sort of fracturing this material up. So I tend to, watch those patients more closely.
When do you bring them back, and when do you find the full effect for SLT in general? I get that question a lot too. Does it work at 2 weeks, at 6 weeks, and when do you make that decision?
So other than pigmentary, I'll bring them back in a week. I actually will have those patients come in early. Otherwise, it's 2 weeks for everybody, and then maybe 6 to 8 weeks after that.
When do you find the full effect? At that 6 to 8 weeks?
So yeah, usually I tell the patients it's really, on average, 6 to 8 weeks. There's some group of patients who are quote unquote these slow responders. We don't know why they're slow responders, but they are, and they can go out actually 3, even 4 months, and then all of a sudden their pressure begins to fall. So, you see them at, you see a pressure of 28, 27 millimeters of mercury. You have them come back at 2 weeks, 27 millimeters of mercury. And is this going to work? Excuse me. Then you have them come back at 6 weeks, about 24 millimeters of mercury. Then you go out 3 months, 18. Excuse me.
So do you, if you're on, last few questions about SLT here, do you guys take people off of medication, besides the PGA, let's say they're on a few different medications, like combos, etc. Do you take them off to find out how the SLT is working right away, or do you wait for a while? Because that's a question I have starting out early on, besides just the PGA one, but the other combos. What do you guys do? Nate, what do you do?
Yeah, sure. So, well, I'll say that in the ideal scenario, you know, they would magically, which actually happens fairly commonly, is they'll auto-taper off their drops before, which is why I make the decision to laser them. Oh, so you haven't taken your drops in 2 months? Oh, should you restart it? Oh, no, don't do that. Now we know you're untreated baseline pressure. Exactly. We're going to do laser. And then we'll look for our 30% reduction and, you know. So if it weren't for the practical limitation of bringing patients back, I would do that in any low-risk, mild, you know, patient without too much damage. So then what I'll say is I usually laser them on drops, and I will peel off a fraction of patients who are not tolerating a drop. Like bromonidine allergy for me is almost an automatic SLT. You know, your drop
and they spike the bromonidine allergies. The pressure goes up. There's some trabeculitis.
And I think when the ocular surface is inflamed from bromonidine allergy, the other drops don't get in. They're always a mess. And you have no option of restarting the bromonidine there. But I think of SLT as the treatment for bromonidine allergy with, you know, replacement therapy. But if it's a low-risk patient on a PGA, I will actually have them stop their PGA a couple days after the SLT, so they come back sort of having already done the replacement. That's just to save them a visit. For me, it's a month after your SLT that I see you again. And I agree, the high-risk patients, and again, you can see someone a month later when their pressure was 16 on a PGA that made their eyes red, and your goal is 16 on SLT. A month is not a long time to wait. You know, if it's someone who's on 4 meds with a pressure of 41, you're trying to avoid a trabeculectomy, SLT probably isn't your move, but if you did go that way, you'd want to see him really soon.
Absolutely.
Yeah, I do like to, you know, again, looking, depending on the disc and, you know, what your you know, prior pressures were and what you think that disc can tolerate. But I do like to get the patients off. You know, I tell the patients, okay, I want you to stop the prostaglandin a couple of weeks before. If they're going to come in, you know, I just say, okay, stop the prostaglandin now. I usually will keep them on their aqueous suppressants because there's a synergistic effect. In other words, going back to my statement before, understand what you're actually doing. In other words, you want a really low pressure, you want to have an outflow drug, and you want to have an inflow drug. So the laser's your outflow drug. You can add an inflow drug to really bring your pressures down. But again, I try to get them off the prostaglandin, and I tell the patients, look, I want your pressure up. I actually want to see what your, as you're saying, what your pressure is without medicines. This way we can really understand what the SLT effect is.
And you don't need to have failure on drops to do SLT. I mean, that's still, you know, it's reimbursed as a primary therapy or as a secondary therapy. I think it's a big misnomer as well. Last question I want to ask you guys, you know, because we want to talk about this whole MIGS world we're in, right? It's exciting, and everyone's talking about MIGS. So, you know, first of all, do you feel, I mean, I know Nate, you've done a lot of MIGS as well. Do you feel like SLT kind of gives you any sense of kind of which MIGS device, or do you feel like it has any sense, or it gives you any idea of where the resistance might be to outflow by doing SLT?
Well, I'll just say that I try to apply some of the things I've learned from SLT to MIGS, meaning that earlier is better, I think, when you're talking about the trabecular meshwork. You know, one thing, and this gets into some of the research I've done, but is that eyes with a high baseline pressure tend to respond to many procedures, and there's another factor called corneal hysteresis that is a predictor of who will have good pressure reduction from SLT, interestingly. And I believe we'll be able to show with other MIGs. So some eyes are just going to respond well, and SLT can be a good indicator that you'll have success. And I think you have some data on that?
Yeah, well, we're working on some data right now looking at, does SLT give us an understanding, you know, where it works, as you've been eloquently told us, is works with the, you know, the pigmented cells and the TM. And so if it works well, there's a thought that maybe that tells you the natural outflow system is working pretty well.
Better,
So does that and change our decision of should I work on the TM or should I work on other part of it.
Right.
But what's nice is we talk about MIGS, and I think what's nice about we talk about inventor canaloplasty as well, which is something we've been doing a lot lately. And I think what's nice about canaloplasty is the fact that it gives you the ability to not just work on the TM. It kind of hedges your bets.
Right.
So you're not only working on the TM, but by kind of dilating that Schlemm's canal and viscodilating, you're allowing to open up the TM, stretch open the TM, open up the the adhesions in the Schlemm's, and also help open up those distal channels. So because we don't have a good assessment right now, that's the problem. There's no preoperative diagnostic tool that says, okay, doctor, this is where the resistance to outflow is.
Right.
And if we had that, it'd be great to tailor, it'd be perfect. But we don't have that. I think what's nice about having a kind of natural outflow system, like an abdominal canaloplasty, is it does work very well from that perspective.